from there. So, as I say, I'm Gill from WALX, and this is Professor Tom Wainwright. And Tom, you are a professor in orthopedics, a physiotherapist, and also deputy head of Orthopedic Research Institute of Bournemouth Uni. Is that correct? I think
That's
I've got
correct.
all of your
Yeah.
titles there. Do you want to just tell us a little bit about what that involves and what your main area of focus is?
Yeah, absolutely. So thanks, Jill. Thanks for the invitation, and great to be here and have the opportunity to chat to you all today. As mentioned, I'm a physiotherapist. I've specialised in orthopedics and musculoskeletal physiotherapy over the last 20 years. I work as a professor in orthopedics. So it's sort of got in touch with Jill over sort of recent months, because one of my research areas is not only treating people with osteoarthritis of the hip and knee. So I've got active research projects that are trying to prevent surgery. But if surgery is necessary, I'm internationally recognised for my work on enhanced recovery after surgery. So if surgery does happen, then we want to make sure patients get the best possible benefit from that surgery afterwards. Now, of course, some of that is about the surgery and the surgical technique and the hospital stay, but actually a lot of it is about what happens afterwards. And I'm really trying to improve care for patients, because I've done quite a bit of work now talking to patients and published articles about my experiences of talking to patients. For many, after a hip and knee replacement, it's very successful and they're absolutely delighted. But there are also a number of patients that we could help and want more, and they want more advice and they want more guidance about what to do, but they also want to know where to go for that advice and guidance. And I don't necessarily think it has to be a physiotherapist. I think it can be groups such as WALX and other groups that are involved in providing physical activity options and social opportunities for people after an operation. So that's how I came to be in touch with Jill, and that's how I've come to be here today. And I'm really happy to share any insights that I may have, but also learn from you through your questions and your experiences as well, I'm sure, as the hour goes on.
Brilliant. Okay, and obviously last time we met was in a very wet park with with a group of walkers with their instructor Andrea. She's actually, I think one of the first questions comes from Andrea. But do you just want to talk a little bit about that sociality that you feel is, obviously we feel that's a really important part of getting people to enjoy their exercise and keep coming back, and we had quite a bit of a conversation around that.
Yeah, sure. So I think the first thing to talk about is we're talking about hip and knee replacement here. And there are about 100,000 people in the UK who have a hip replacement, and about 100,000 people who have a knee replacement every year in the United Kingdom. So there's lots of people about, and there's lots of people to help. Now, the primary reason for most of those people having that hip replacement will be osteoarthritis. So in the first instance, one thing that's important to realise is that the best possible treatment for osteoarthritis, until the pain becomes unbearable, you need surgery, is actually exercise. And that's both local muscle strengthening around the joint and also cardiovascular exercise. So exercise that improves your stamina and your aerobic fitness. The other things that we need to educate patients who have osteoarthritis is that movement is good. Quite commonly, as soon as something starts to hurt, we stop using it. But actually, if we stop using it, then it becomes stiffer, more painful, and actually things can, get worse a lot quicker. There's good evidence to show that doing the right kind of exercise helps you if you've got osteoarthritis. But the evidence also tells us that exercise or physical activity only helps with osteoarthritis for as long as you keep exercising. It's not a case of if you just do it for 6 weeks and then it helps and then don't have to think about it again. It becomes something that you need to do on an ongoing basis. And you may then find that that will prevent the need for any surgery in the future, or it may delay the need for that surgery, or it may put you in the best possible condition ahead of any surgery in the future. And of course, one of the main things that if we're going to keep doing an exercise, if I give a patient a boring sheet of exercises that they have to do in their home on their own, it becomes laborious, it becomes tiresome. So if we can combine exercise or physical activity with something people enjoy, and a social aspect, a cup of coffee, a cup of tea afterwards, and a bit of laughter and a bit of fun, then I really think people are much more likely to keep going back. So therefore, they're much more likely to get the benefit of that exercise. So WALX groups are one example, but I've also been involved in a trial funded by the National Institute for Health Research, which I've been leading locally in Bournemouth, where we've been using static cycling for people with hip osteoarthritis. And we've found an 8-week program of static cycling in a group experience with social sort of activities afterwards is much better than physiotherapy at reducing pain and improving mobility for those patients. Now, what is it about that intervention? It may be the cycling and the group, but we think there is a lot to be unpicked about the group dynamic and about socialization and meeting people. If we then think about joint replacement, we also know from research is that after hip and knee replacement, when patients are given questionnaires or surveys, at 6 months post-operatively, around about 20% or 1/5 of patients would answer certain questionnaires about social isolation and loneliness to say that they were lonely or socially isolated. We can also look at the evidence that tells us that whilst many people make improvements, the majority of patients don't increase their physical activity after a hip or knee replacement. So therefore, there's two issues where we want to get people more active, but often they don't know how to do that. They need some encouragement. And we've also got some other people that actually are quite lonely and isolated, and they've sort of been left from the health system. They finished their physio and, you know, perhaps they've been said, right, do it yourself. But then quite often they don't know how to do that or where to access that. And so I think socialization, both if you're trying to prevent a hip or knee replacement by exercising, is important. I also think it's really important afterwards. But then I also think this is just general advice. I'm much more likely if I go in a group and exercise that, you know, some people like doing it on their own, but I think it's much more fun.
Brilliant. And that really works with what we try to do. We just try to inspire people and get them out, help them along the way, but keep them coming back and keep them progressing. And I think most of our walkers will agree with you on all of those points, although a lot of them might also want to add cake with that coffee, but you know, that's another story. As you know, we do have quite a high percentage of participants or walkers within our groups who are either waiting for hip or knee recovery operations, recovering from them, and coming to us at different stages. And so some of the questions are going to be from maybe the instructors or the physios that have referred them. And then we've got another cohort who are doing their utmost to wear out their new hips and joints, and they're regularly exercising. And I think that's something that I've been really surprised about is how active some of them are and how engaged they are within the program. So there's a few questions that relate to all of those things, but I think what we'll do first is start with some of those regarding people coming out and recovery. So if I start with one from Andrea, who you actually met, the instructor, she has asked you, some orthopedic surgeons still follow hip precautions of no hip flex 90 degrees, no crossing legs, no internal rotation. Obviously, people should not be forcing it or working too much through discomfort anyway. But when do you think it would be okay to join in all of the exercises that we do have on offer within our classes, rather than adapting them for those with the total hip replacement?
Great question. So for those on the call, the first part to probably talk about is what is dislocation. It may be something that people have heard of. So dislocation is the hip is a ball and socket joint, and it's when the ball comes out of the socket. It's extremely painful. It happens in a very small percentage of patients after hip replacement, and most commonly in the early stages of their recovery, when things haven't healed and secured up securely. Now, you can be at risk of dislocation for a number of reasons, but also there are a number of different factors that can change your risk. The components used and the head size of the hip replacement, the surgical approach used by the surgeon. So I'm not going to give any definitive guidance, because each surgeon will have their different choices and therefore may ask patients to follow different protocols. But if I can in general say that after most surgeons, typically across the UK for sure, if they are using precautions, they would ask people to uphold strictly to those over the first 3 months. But after that stage, when healing is incurred, I think they would then start to say you can return to normal movements as your own body allows and as you are comfortable. I do think it's important that people do realise that hip replacement isn't a natural joint. So, we always say to patients beforehand that you may not get the range that you had when you were in your 20s, but actually you'll get, more than enough range to enjoy, the activities that you need to. So I would say in specific question to Andrew is that, of course, the first bit is for any specific patient, they should always follow their health profession and surgeon's advice, because they'll know more about the history than I do talking on this call. But I think what you can then also say is, if the patient says, oh, well, I can't bend my hip over 90, I'd also explore with them and say, okay, well, how are you putting on your shoes and socks? And if they then demonstrate to you how they bend down and put their shoes and socks and bend over 90, you can probably say that actually safely they're probably doing it in some circumstances and are unaware of it. So therefore they could probably then, not completely disregard the precautions, but join in a little bit more and do more than they perhaps think that they should do. What's interesting with the precautions is I think they're very, very much needed when they're given, because I don't think with a hip replacement you get anything by trying to do anything too quickly in the first few weeks. I think it's sensible to allow things to heal, but then once that healing process is undertaken, the ligaments, the capsule have all tightened up around the hip, the muscles have got stronger, then patients should be able to return to most of the things involved in a WALX style exercise.
Fantastic. And that sort of leads into one that came from several people, both instructors and participants, was, do you have strong feelings about when people should start? And I know that when we went out into that wet park, there was a lady and she was literally just allowed to drive, and so had turned up, and instructors often call us at head office and say, should I be doing this if the person really wants to? So is it 12 weeks or before, or different for every person?
Of course, it's going to be difficult to give overall guidance because there can be such variation in patients. I think a good rule of thumb, if you were looking at anything, would be to say to them that after 3 months they should be at a level that they could return. But obviously, if you've got good relationships with those people and and they're already telling you they're back walking on their own, doing their own walks, it's common for patients to come back in to see me in clinic 6 weeks after the operation, and they can say, yeah, I'm back walking a couple miles, I've lost my sticks, I'm doing absolutely fine, But of course, some other patients can be quite hesitant because they're worried that they may damage it. So those are the ones when I'm seeing in clinic, I'm encouraging to do a bit more. So I would say if any patient is unsure, they should talk to their health professional, whether that be physio or surgeon or whoever they're consulting for their healthcare at that time. But in terms of your leaders of walks, I would be talking to them and saying, okay, well, before you join a walk, how have you been walking for an hour at a time, on your own? Is that something that you do? And I would encourage them to have that kind of conversation so that they know that they have been doing it, and it's not that they've just been sat at home and the first time they're going to come and do a walk, they're just going to come and try it with you guys. And of course, as you say, we met at Upton on a wet and windy day with mud and slips and stuff. So of course, that will and hills and uneven ground. So of course, that's going to have bearance. If that's quite different from a nice sunny day with clear tarmac and a good walking surface, because people will have gaining confidence with their balance, etc., as well as their walking ability afterwards. So yeah, give an absolute answer, but I think if you wanted a rule of thumb, I'd say to be on the safe side, I'd wait 3 months, but there may well be patients at 6 weeks that are absolutely fine to go.
And somebody, and again, I think 2 or 3 people asked, when should people be almost pain-free, if ever, after a joint replacement? And that seems to come up a lot. People saying, should I be pain-free by now?
So it's a great question. So when we're consenting patients for operations, we are talking about the risks and benefits of surgery with patients. And, these operations are very successful, but they are major surgery. And there is, of course, a risk that when you undertake them, that your pain may be worse or not improved afterwards. If I talk in general terms, 1 year post-surgery, when we look at the research, about 15 to 20% of knee replacements, patients report some ongoing chronic pain or not full satisfaction with the function of their knee. And for hip replacements, you'd probably say it was a bit higher, about 90% at a year, 90 maybe to 95 are happy and pain-free. What I would say is, it's really difficult to answer because there are so many elements that link into that. Because of course, we're not just a hip or a knee. The patients may have other conditions and other things going on. Commonly it might be that one hip gets better and then the other one starts hurting, or they may have other conditions that limit those things. So it's really difficult to answer, but in general terms, that would be the percentages. When a patient comes to me, I say to them, you can think about your recovery in this way. By the time we see you at 6 weeks post-op, you'll be doing most things around the house and be wanting more specific advice about returning to work and all your normal activities. I then say to patients, by about 3 months post-op, you pretty much be, most people would start to recognize that you were getting back to all the things that you would do. But between 6 and 12 months, you would start to feel fully recovered. And again, maybe that would be the hips slightly earlier than the knees. And maybe the knees, it might take 12 to 18 months to be fully recovered. But there's so many variables around that, because there's also things about, we may know how well the surgery's been done, but if you're not going to do any exercises or strengthening exercises or the guidance that you've been given afterwards, then you can't expect to get any stronger or better. So there is a certain element of how much the patient does. And of course, there's a flip side to that, because some patients do too much, and that can then be the cause of pain because they've overdone it and done it too quickly. So again, that's where I'm really happy to support sessions like this in any way I can, because I appreciate getting that balance right after surgery, the right amount of guidance, but not too much, the kind of Goldilocks, not too much, not too little, can be a hard thing to judge. And I'd say to most patients, there'll be times in their recovery where they overdo it. They feel great on the day, but they overdo it. So they then need to rest for a few days, learn from that, and then, take it forward by not doing as much and then building back up again. So yeah, great question, but not a slam dunk answer that I can give you, which will probably be a theme this evening.
That's absolutely fine, and we know you're not consulting with an individual here, so that's fine. And it's the classic case of listen to your body and talk to your instructors, your professionals, if you've got any concerns. Bob is waiting for his operation, so he's on the other side and he's trying to do as much as he can, and we do see that, and they're trying to stay as active as they can. He said, how can he best prepare his fitness for his knee operation? How can he ensure it's a success, and what type of natural options are there for pain relief, as he doesn't like taking drugs? So you've got 3 questions in one from Bob.
It's a great question, and the fact that he's asking it, I'm sure he's probably doing most of the things I'm going to list off, because he sounds pretty motivated. So I would say the first thing is, keep as active and keep as fit as you can. And when I talk about that, I talk about your cardiovascular fitness. So you want to ensure that you keep your heart and lungs working well, because it's a major operation having an anesthetic. So that's important. And then also keeping the movement in the knee as much as possible with range of motion exercises, and also keeping the strength around the knee as much as possible. Now, I'm sure he's, but it sounds of it, he's sort of well tuned in and doing those exercises already. I think in terms of the cardiovascular fitness, I would recommend low impact or non-impact cardiovascular exercise. So that might be swimming or cycling or those things, because they may help to reduce the impact through the joints. Or if you're walking, of course, poles reduce the impact and weight through your joints as well. So I would urge all of those things. I would also say I would try and eat sort of balanced, nutritious diet, and try to ensure that you follow all the guidance in terms of healthy eating and healthy lifestyle. There's some evidence to say, I'm not saying Bob's a smoker, but you should give up smoking before an operation. That can reduce your risk of complications, and you should also try and reduce or moderate any alcohol intake if you're a heavy drinker. There's one question also I saw that was coming through, which was about dental and oral health. That's quite an interesting one, because there is some links between increased risk of joint infection and if you've got infections within your gums or teeth. Now, what we may not realise, unless we're getting dental checks regularly, that a lot as we age, we can be having those and we're not aware of those. So if you haven't had, just to combine the two questions, if you haven't had your a trip to the dentist recently, a trip to the dentist, if that's something you wanted to optimize, would also be a good idea. I think there's other things that might be interesting are to prepare your friends and family. So depending on whether you live alone or with someone, I don't know what Bob's situation, but if I talk more generally, most hospitals in the UK now, after a hip or knee replacement, you'll be in, if it's straightforward, anything between going home on the same day in some hospitals or staying 1 or 2 days, probably in most places. Some patients may stay longer, but when patients go home, you'll be typically walking with a couple crutches, walking short distances, so you will need that bit of support around the house. It's hard to carry a cup of tea from the kitchen to the living room when you're on 2 crutches. So I think the other preparation you can make sure you've got the stuff around you. So if you live on your own, get some meals ready for the microwave or get people to pop in. And if you are living with someone, try and make sure that they appreciate what they'll have to do for a few weeks. In all of our relationships, we have different ways of working, who does the cooking, who does the cleaning or whatever. So if you're normally the one who does those sort of things, you may need the other person to pick up the slack. So I think getting the wider family and friends to understand what you're going through can be so helpful, because then you've got that support network as well. So yeah, physiologically, keep yourself fit and healthy, eat well, strengthen, cardiovascular exercise, stop smoking if you smoke, limit alcohol intake, and then if you want to, check on oral health and those kind of things. But other thing to say is also there was about the pain relief. So there are different ways with pain. So a lot of people don't like taking tablets. Topical analgesia is something, when I say that, that's when we mean like rubbing in a cream. So there are some good non-steroidal anti-inflammatory creams now. These have the benefit that they have, especially on joints like the knee, there's good evidence for them. And then you also limit the problems with stomach ulcers and those things, because you're not having the tablet in your stomach. So you may want to try those sort of topical creams. There's, of course, other things that have the kind of heat element to them in creams. The capsicum creams, they work in a slightly different way. The evidence for those is less strong, but lots of patients report that it helps them. I'd also say that I have lots of patients that report to me a whole number of different things help them, all the way from my mum, who swears by cider vinegar, but I don't know how she drinks that every day, to cod liver oil, to glucosamine and chondroitin. What I'd say about those supplements is that I know that they help some of our patients, but we don't have the research evidence that is strong enough to support them in what we call randomized controlled trials, where there's proven evidence then they're better than placebo. If there was, then we would be prescribing them to all patients. So, but that's not to say for some patients they work. So if you can afford them and they work for you, then there's those sort of pharmacological options as well, which a lot of people use.
Fantastic. So we've got one now that's specific about knees and kneeling. And so there's a sort of precursor and then the question. So I think this one was Elizabeth Curley. I may be wrong. I apologize if it wasn't. I understand that following knee replacement, some people have difficulty kneeling or are advised not to kneel, and some don't have a problem. And I assume the actual prosthesis and the amount of disease and deformity plays a part in this, but my question is, does the brain also play a part in this? And if you don't actually move the joint and the ligaments and tendons into that kneeling position routinely before surgery, do the pathways, not sure if that's the right word, she says, in the brain also atrophy, or, want of a better word, resulting in the brain thinking that that movement is no longer required? So should I practice kneeling on cushions, which is uncomfortable due to bone on bone, knee arthritis and loss of range of motion, or not? Quite a long question, but quite a good one.
It's a good question, and it's a real common question with knee replacement. So, and this will really depend where you are in the country and your surgeon and the team that you're under. Kneeling after knee replacement can be difficult, and for some people, they find it's too sensitive and too painful afterwards, and for some people, they manage to get back to it. I think it's something that ahead of your knee replacement, it's great that you're aware of. That's one thing I'd say, that not all patients are always aware of that. Depending where you are, that may not have been explained, to you. In terms of before the operation, where I think Elizabeth was describing that, where she's from at the moment, I think keeping as much range in that knee as possible is a good option, and keeping as strong as possible. But if you've got severe arthritis that needs a knee replacement, I wouldn't be forcing it at this point, because I think you'll just make more painful. So just keep within a sort of a range that is tolerable, rather than forcing it. In terms of after the knee replacement, you will have some altered biomechanics as they put the new prosthesis in, which will make it difficult for some people to kneel, but it is possible to kneel afterwards. And I think one of the points that she raises is really important. That's about sensitivity. So what's interesting, and I talk about this a lot with patients with their scar or with their incision, is that a lot of patients get quite sensitive across their scar, either after their hip or after their knee replacement. And after 6 weeks of surgery, something that I teach all patients is scar massage. So once the scar is well healed, I encourage them to start touching their scar. If they're not doing that, massaging a moisturizing cream in after they've had a shower. Now that starts off, if they've not touched it much, with a light rubbing, to a more firmer motion. Now, the real point of that is to retrain the brain that actually touching that scar is not painful. Because, of course, the brain is hardwired, because anything in the area of the hip or knee immediately post-op, the brain is thinking, oh my God, that's going to hurt. That's my hip, that's my knee that I've just had operated. So once we get past that initial healing stage, there is a certain amount where you have to rewire that and touch it and give it some firm touch. I'm showing you on my hand, but obviously I'm meaning my hip or my knee. And get that area to know that actually, the healing process has happened and the pain is past. So I'd start by putting pressure around the knee and over the knee. And then I wouldn't try and go straight into kneeling straight away. I'd start by pressing the knee, up against a sort of we train people to kneel is we get them off a soft surface to start with, and we do a partial kneel with offset with weight on the other leg. And then over a number of weeks, you increase the amount of weight you put through that knee, you increase the depth of the knee bend. And what you can find with most patients is, over a period of time, they can accommodate and get used to that feeling. Now, there will be some patients who biomechanically, it won't be possible, either due to the size of their leg or their specific biomechanics. But for lots of patients with a graded program, nice and patient, and taking your time and some good guidance, you can get back to kneeling afterwards.
Great, thank you. There's a couple of questions that I want to come back on because you mentioned the cycling and static cycling and that kind of thing.
Yeah.
For people. So Anne's York has said, what's the most important thing? Is it the movement, or is it to increase resistance? And she doesn't mean just as recovery, she means sort of generally as a prevention of staying in better shape. What's most important, the movement?
So great question. So if anyone and I can put a link in the chat towards the end, if anyone has hip osteoarthritis, we have an app available that is a free app that has our cycling program for hip osteoarthritis available on it. There's videos on that about how to cycle, why you should cycle, what exercises you can do. If you go onto the either the App Store or the Google Play Store, depending on whether you've got a iPhone or a Android, and if you search for Ori Education, you'll find an app in the App Store, and within that app is something called the Chain Program, which is cycling against hip pain. And in that, there are loads of videos and about how to cycle and how you should do that. There are videos about how to set up a static bike, and then there are videos 30 minutes long over an 8-week period that take you through a full cycling program. What we do in the program for people with hip osteoarthritis is we emphasize that it's not about increasing resistance, it's about increasing cadence. So that's the speed of which you spin your legs. That program caters for people all the way from their 30s and 40s to their 70s and 80s. And we're aware that some people within the class, when they come to that, they're pretty fit and they want to put the resistance up and they're able to do that. But there's other people that haven't been on a bike for 30 years. So for them, just the movement of cycling is enough. But what we focus on is increasing the work by increasing the leg speed rather than increasing the resistance. And we do that because we actually find that increasing the resistance can put pressure on the joints, and then the patient can actually have more, slightly more pain from the cycling activity, when the whole point is we're trying to ease the pain. What I'd say is if you're going to start static cycling, stick with it. The first few minutes, if you've got an arthritic hip or knee, it feels stiff and painful. But then most patients say after about 4 or 5 minutes, it really starts to ease off. And if you do it for about 20 minutes, it starts to feel really good. If you can build that into your sort of daily or weekly program, do it 2 or 3 times a week, you'll really feel a benefit. And we've published that work, and that work, as I said, is available free to download on a patient app under Ori Education. So great question.
Right. Well, thank you for that one.
There was another question in the chat as well about gyms in parks. Did you see that one?
Yeah, I did, and I was going to say that came in from WALX Harrow, and I know we've got a lot of groups that have got permission and actually do incorporate them quite a lot. So I was going to say this is really useful information for those instructors who are coming across bits of kit. And I know that I've got instructors that are even working with their council saying, come on, put some more stuff in that's suitable for the older adults, so we can do more and more and more within our walking sessions. So what I would say to WALX Harrow is absolutely, as a WALX instructor, and also go to your local council, go to the owner of your parks, and say, look, I can be here at a certain time and help people, because we've all come across those people that are giving it a go in the local park but don't really know what they're doing. Did you want to add to that, Tom?
Yeah, I think it's great. And it's also to say there's quite a lot of those that can be upper limb exercises. And of course, if you're trying to improve your cardiovascular fitness, you can sit down and do one of those presses and give yourself a bit of get a sweat on without moving your hip or knee. Do you know what I mean? So the upper limb exercises could be a great exercise for, not only your cardiovascular fitness, but getting your arms stronger for using the crutches in the first few weeks after your surgery as well. In terms of the lower limb ones, I've just got a picture in mind of one that I was using in France with my 10-year-old daughter last week. And it was one where you put your feet in and you go sort of like that. There are some in those parks that I'd say be careful with if you're immediately after a hip or a knee, because, I don't think my 10-year-old was using it how it was designed, but they would definitely could give you some movements that you might not want. So, yeah, with the right guidance, I think it's a great idea.
Fantastic. And then somebody's asked, could they swap out their crutches basically for the WALX rehab poles? Is there any reason they shouldn't do that initially at home?
So again, I would say that's a sort of person by person basis. So there are people that are really comfortable with crutches, and there's some patients who prefer a walking stick. And there are some patients that quickly progress just to one or the other. I think if the poles are something that you are familiar with, they could be useful. The one thing I would say is, remember, after your operation, you may be reluctant to put all of your weight through your operated leg, and you may feel you want some more stability, and an elbow crutch will definitely offer you more of that than a walking pole, the ones that I've used. Whereas when you progress, then you may obviously prefer the walking poles because they allow you to walk quicker and more normally, and for all the reasons that many of you use them already.
Okay. So we have another question, and you and I had a brief chat about this beforehand, so I know what your answer is. But a couple of people now have asked that they've read in the paper about a magic goo or sort of compound that is going to revolutionize treatment for osteoarthritis. Is it likely to be mainstream? Is it going to be available anytime soon?
Well, I spoke to you about that because I hadn't seen the press release or that news article, and what I'd say about that is, quite often we see stories like that, specifically in certain newspapers or certain outlets where companies have got new products. I think if research emerges, and that's rigorous research that's done, that provides us with good long-term benefits of new things, then we will start using that within healthcare. So to reassure people, there are lots of researchers like myself always looking for new ways to help people, but there's also organizations like NICE, the National Institute for Clinical Excellence, that look at new products like this, and if products like this have clinical and are cost effective for our health system, they very quickly recommend them, and that gets communicated to us as health professionals, and they then become available. So at the moment, magic goo isn't part of any sort of NICE guidance or best practice guidance. It's not to say it won't come in the future if they complete the research necessary. The other thing I would say in general about osteoarthritis is that actually, for a common disease that will affect most of us as we age in multiple different joints, it's actually a disease that we know very little about. And believe you and me, drug companies and medical device companies have spent billions of pounds over the last 30, 40 years thinking about drugs for osteoarthritis, but also things like this magic goo or other devices. So they do that because obviously the market is so big that if they can crack it, they've really hit the jackpot. So what I would say is that, we'll hear every month in the news about a magic goo or another product. So just be wary of that. And, it may be that you get invited to take part in a research trial as part of your care for something like that. And that's great, because then it's being conducted and it's being monitored well. But probably don't part with your own money for something that hasn't got clinical evidence behind it yet. That would be my advice.
Okay, and that leads into a couple of questions, and I think this is from people considering their options. One is Bernice has just asked, what other methods could help other than surgical procedures, e.g. cortisone injections? Are they any good? And then the other question that links to this is, would a knee replacement help with range of motion to allow me to walk down hills and stairs? So, is it definitely going to help in that regard?
So first thing about the knee replacement, as I said earlier, it's a major operation that has risks and benefits. So you should go in open-eyed. As I said, a year after surgery, 80% of knee replacements are very, very happy. 20% are less happy to a varying degree. But in the main, it's a really successful operation. And if you go and get a good hospital and a good surgeon, and then follow all the guidelines of rehab, I'm sure you'll do very well. And I'm sure that particular question, you'll get back to walking no problems. But there's no guarantees, and I think sometimes we need to be careful when we're talking to patients about this, because they're so routine and so many are done. People can forget that it is still a major operation. So it's not just the risk of it being more painful afterwards. There's also major medical complications that can be associated with major surgery. And so that's why it's important that clinicians such as myself talk really openly about this with patients, so they have all the information, so then they can make their own judgment. And that judgment is when the pain's got to a point where they really can't go on, and they want to, have the operation. The second part about injections. This is probably more where there's some different views, and it may depend about what stage of osteoarthritis you have, or how much arthritis you have, or whether it's of the hip or if it's the knee. And there are differences in clinical practice across the country, and also differences in clinical practice between the NHS and within the private sector. So typically, and in my own hospital, the surgeons I work for, we've stopped doing cortisone, routine, cortisone steroid injections for arthritis of the hip, because there's evidence that that can accelerate collapse of the femoral head and reduce the bone stock, which can lead to more pain and also a more difficult operation in the future. The other thing to say is that with these kind of pain-killing injections, they can last for a couple of days, a couple of weeks, or a couple of months at best, but they're not actually changing anything other than giving you that short-term pain relief. So what will commonly happen is patients will come back and want another one, and there'll be a diminishing return of the pain relief, but also an increasing chance of, as I said, weakening of the bone from the repetitive, steroid injections. There is work looking at sort of stem cell injections, and these are probably more often in the knee, and again in different parts of the country. Again, these are probably more found in private practice, not routinely in the NHS. There's emerging evidence, but at the moment there is not guidance on a national guidance that's what we should be doing for knee osteoarthritis. If you look at the NICE guidelines, the 3 things that they recommend as the core treatments for osteoarthritis are aerobic exercise and local muscle strengthening, weight loss for those patients who are overweight, and education and advice to patients about treatment options, about lifestyle modification, pacing, and also around the fact that with osteoarthritis, if you actually exercise, the pain will get less. When those 3 things stop working and you've done those things, in their entirety, that's when, surgical options may be what you need.
Right, fantastic. And this one's a little bit like the one we had before about the hip flex from Andrea, but it's about tall people in particular. Curly, who asked this one, said she didn't want any tall people to panic about this, but she had noticed that she had 2 particularly tall people who had problems 18 months or so after, and she just wanted to ask whether there is some evidence that taller people might be more prone to it.
It's a really interesting observation, but there's no evidence in the broader field that there's any link between height and dislocation rate. So to reassure any tall people or different, that wouldn't be a particular risk factor. It's an interesting observation though, and of course I don't know the circumstances, but in general terms, there wouldn't be any difference. If we look at the actual research evidence that's linked to dislocation, if you look critically at the evidence, the main thing that makes a difference, this is assuming the surgery is done correctly and the components are put in the right place, is the size of the head that's used. And I was involved, my first research job 20 years ago, I was involved in a multi-center trial where we evaluated what the difference between a small head and a larger head for dislocation rate. And we proved that using a 36mm head composed to a 28mm head reduced dislocations. And now the standard across the country is that at least a 36mm head is most normally used, and that's because we know that has a lower dislocation rate. So it's far more likely to be something around either component malalignment, so something's not gone right in surgery, or commonly in the early days post-surgery, a patient slips or trips, and that causes the hip, and it's a traumatic dislocation.
Right, okay. And then we probably finish on this one unless there's any that come in while I'm reading this one out, so we can wrap up within the hour. This comes in from John Chalice, and he is one of our instructors, but he says, before I retired as an orthopedic surgeon, I was fortunate to work with a team in which physiotherapists work closely with me pre and post-op, with the assessment and rehabilitation of hip and knee replacements. If I were to be delivering hip and knee surgery today, I would actively encourage walking with 2 poles before and after, enlisting those with sound experience and training in this field, like instructors like John. Do you share these views? And if so, as a practitioner and researcher in this field, is there any way you think that you might be able to go about encouraging that with other people?
Well, I think John and I are on the same page. I agree, and I'm here because I'm on the same page. So what's interesting to share with you is that for all the research done about the rehabilitation after hip or knee replacement, I published an article with Danish colleagues a couple of years ago. If we look critically at the research, there's still no perfect recipe for rehabilitation. And there's emerging evidence that has looked at whether physio-led exercise is any better than patient self-directed exercise after hip or knee replacement. And they found in that research that there was sort of no difference, which is a bit condemning, really, of physio, my practice. But I think it also, what I think it also highlights is actually how with physio, we don't have the ability in terms of resource and the time to spend with patients to take them to that higher level of functional recovery. For those who've had a hip or knee, they will have had their physio afterwards, and you get to a point where you're walking and all those safe things, and then because of the volume of patients within the NHS, you can't see the patient on an ongoing basis. So therefore, I think it's really important, and I really agree with John, that clinicians and researchers like myself link in with organisations that already exist in our community, such as WALX, and there are many others, and say, hey, we want to signpost our patients. Once they've finished with us, we want to signpost them so they can continue to rehabilitate with you guys. Or it may be another group. It might be hydrotherapy. It might be, a different type of, gym group, or it might be bowls or dancing or whatever it is. But we need to be able to signpost those, and then we need to be able to share and answer questions just like you guys have asked tonight, so that we make those relationships closer for the benefit of our patients. I'm here today because I want to make those links closer, and I think John's completely right, and I'm trying to do what he said he would be doing. So yeah, here.
Right, and well, I will like to add on there that John did have a PS that he's got personal experience in more ways than one, because he's had 4 hip replacements, 3 on the same side since his retirement, and he's obviously used poles throughout all of his rehab. But I will also share from a perspective that anyone who hasn't met him, he is still leading walks at 85. So that's an advert in itself to what we're talking about today. I would like to thank you very much for today, for helping out. And I know that from the instructors and the physios that we are interlinking with, referring backwards and forwards, it's music to our ears that we've got somebody like yourself that wants to strengthen those pathways and get it, because quite often we need advice. We need to be able to send people back when we're not happy, and we need to know that there's people we can do that with. So just thank you very much. It's been brilliant. I don't think there are any other questions now, Tom, so thank you very much. That's been
my pleasure. Thank you so much for the invitation. It's been great to answer the questions. Yeah, it's always difficult because you have to answer generally. I don't know anyone's personal circumstances, so I hope you'll forgive me. And it's also, many of the questions multifaceted, so there's no black and white answer, but hopefully I've given enough insight without sitting on the fence too much, and been helpful.
No, it's been really, really helpful, and people are coming through and saying it was very informative, and I'll share all those with you afterwards. So let you get back to the family, and thank you very much for your time, and let's do something else soon.
Yeah, love to. Thanks all. Have a great evening. Nice to see
Thanks,
you all.
Tom.
Take care. Bye bye.
Bye bye. Bye bye.